So inspection, Dr. Anderson's just going to take a look at Crystal's abdomen.
I want to look whether it's flat, whether it's ovoid, whether she's pregnant or not. I see scar marks there and in the umbilicus, so you obviously want to be looking for that. And from my standpoint, with the number of shingles that I see lately, sometime during this exam you need to look at her back and see whether the pain that she has in the abdomen is coming from shingles that are starting on her back.
Sorry to interrupt.
I know, I forgot to tell you, we're having an AV problem today, right, Mitch? Which is audiovisual. And we don't have a connection for the screens, but we're taping. So now this will be part of the tape too, right? This discussion. We're taping so that we have the film for it, but if you need to see closer, feel free to gather around, but maybe don't crowd Dr. Anderson's personal space, right?
I'm okay.
He's okay with it. Okay. So scoot up if you can't see, but we don't have the capacity, and that really shows us how much we appreciate and rely on you, Mitch. So, okay. So Dr. Anderson did an inspection of the abdomen, and now he's able to auscultate. He's going to listen for bowel sounds in the 4 quadrants, and then he's also going to auscultate for renal artery breweries bilaterally. The picture of that is on 454, if you recall. When you're auscultating, really, it sometimes takes even up to a minute to hear and appreciate bowel sounds. So you can't kind of just, unless you hear them right away, take that few extra seconds to make sure that you're waiting to hear, okay? And you can practice that today too. I thought I saw a hand up. So, let's see. We've done inspection, auscultation, percussion. This is a great day to, again, practice percussion. I think percussion's easier on the abdomen than on the anterior and posterior chest wall. So this is a great day to practice that technique with your attendings. And you're going to percuss in the 4 quadrants. And when we get to the abdominal exam, we're going to go really in depth as to which sounds we're hearing. Basically today, just want to hear for basic tympany, which is air in the intestines. And so one of the biggest things you can do today is make sure you've got your percussion technique down while the patient is supine. That's sort of newer for you, even doing it while they're sitting up quite a bit, right? Okay, so next we're going to palpate. And what you do is you palpate light and then deep in the 4 quadrants. And you could palpate the kidneys first, either way. So, but let's start with palpating light and deep in the 4 quadrants.
Light to me is one-handed.
Yeah, we usually do one-handed light palpation, the pad of your hand. I was going to say lightly, but that's implied in the term.
She didn't wince.
Deep. And we all just had lunch, so this might make you a little nauseous when you're practicing on somebody else. And see how deep Dr. Anderson's actually pushing. When I press on for a deep palpation, my fingers turn red. That's how hard I'm pressing. Those of you in Dr. Stewart's group, this is one of her favorite things to do, is to show students deep palpation of the abdomen. I think she likes to make you physically sick. So if you already don't feel well, you can probably abstain if she calls on you. But what she likes to do, a lot of us are trepidatious, if I would use one of my favorite words, at pressing too hard. But she wants to show you how hard you actually have to press, and while you're pressing, you're also feeling, and you can actually feel quite a bit. So practice that on each other. Many of your attendings today, I think, are going to tell you exactly how hard you need to push. And do you do that as well?
Oh, you bet I do.
Oh, boy. Okay. So now let's palpate the kidneys. They're not that easily palpable in an adult, except for patients maybe with polycystic kidney disease, which I don't think you've touched on yet. Patients with lots of kidney cysts, that the kidney can become as large as this piece of paper with cysts. And so that is rare to get to that extent, but patients with polycystic kidney, you may palpate the kidney a little bit easier than others. Let me just tell you that I always like to tell you realistically does anybody really do these exams, you know? And so this one, palpating the kidneys, you really won't see very often. but when you're with a nephrologist, you will, and you'll know how to do it as of today. One more notch on your belt, right? One more thing you know how to do. What was I going to say? Yeah, so not intensivist, that's what I was going to say. In the ICU, we'll do that too. So it does occur, you may not see it, and raise your hand if you've ever seen somebody do it in your shadowing experience. It's also hard to feel, so I asked, remember this morning, I said, if anybody can palpate a kidney on somebody else, don't have to tell me who it was, but just come in the hallway and say, Dr. Abadi, I actually felt a kidney. And I just wanted to see how many would come and do that to me, and tell me that. One person. So if you happen to feel a kidney, then let me know. But it is, actually two people, one other person thought they did. And then his partner said, no, I think that was the table underneath me. So, deep palpation. If anybody can feel a kidney, I feel that it is this group of osteopathic physicians in the making, don't you? Right?
Yeah.
Marvin, right? Yes. If anybody can do it. So I challenge you today to do this and learn how to do it well. We're going to walk through it. We're on page 463. And basically, Dr. Anderson, I'm going to walk you through this. Approach the patient from the left side, which you are. And notice how Crystal has her knees bent. You can examine a patient, abdominal exam of a patient with their knees bent or with their legs straight. With their knees bent, you can see that the abdominal musculature is going to be more relaxed. So that is why we're doing it that way. You can do it either way. If your patient's got their legs outstretched and you feel like the abdominal exam's a little hard, try to have them bend their legs just even a little bit, just to get a little bit of slack there. So, Dr. Anderson, place your right hand behind the patient below and parallel to the 12th rib. And lift your right hand, attempting to displace the kidney anteriorly. The person who felt the kidney this morning also told me they were in an anatomy dissector, and they really knew exactly where to find that kidney, which reminds me of an anatomy story when I was a student where I dissected the kidney so well they showed it to the other people in the anatomy lab.
Good for you.
Thank you. And so that was a good moment for me. So you're kind of displacing the kidney anteriorly, and then with the, at the same time, place your left hand in the left upper quadrant, abdominal quadrant, parallel to the rectus muscle. Ask the patient to inhale deeply and hold their breath while trying to capture the kidney between the hands.
Now let it out.
It sounds so much easier than it actually is to do.
Still didn't feel it.
So, you didn't get anything.
Oh, I had her take her deep breath and.
Sure, we were just talking about deep palpation. Okay, and so now we're going to, did you ask the patient to exhale and then stop breathing briefly?
Yes.
Okay, so I just want to capture what Dr. Anderson did. After he tried to capture the kidney between his hands, next he was going to ask the patient to exhale, then stop breathing briefly while lightening the anterior abdominal pressure of the left hand to try to feel the kidney returning to position. It's pretty subtle. I'm going to challenge you to try to see if this works for you, and come tell me if it does. Now we're going to do the left kidney alternative two-handed technique, and approaching the patient from the right side, and that's why Crystal just switched so you could see better. Thank you, Crystal. And with the left hand, reach over and around the patient to attempt to lift up the left kidney. Okay, so remember your anatomy, you gotta go pretty far. And with the right hand, palpate deep in the left upper abdominal quadrant.
Deep breath
Ask
in.
the patient to inhale deeply and hold breath while trying to capture the
Now,
kidney between the
exhale.
hands.
You don't have kidneys.
Okay, we're trying. And the right kidney. Now we're going to try the right kidney. This is on page 464. There's a picture there. And approaching the patient from the right side. Remember, the abdominal exam is traditionally performed from the right side. Let's see. Use the left hand to attempt to displace the kidney anteriorly from the back. And use the right hand to palpate deep in the right upper abdominal quadrant.
Nice deep breath. And Let it out.
Got nothing?
Nope, and I'm going pretty deep.
The next part I'm going to tell you is something we do all the time. So that's when we are going to tap on the person's back to see if they have
Facing that
tenderness
way.
right over those kidneys. So have you heard the term Lloyd's punch? That's the way it was always called. Raise your hand if you ever heard that phrase. Now we call it CBA tenderness. That was kind of when I was an intern.
It's also known as McMurray's. We looked it up this morning
Really?
on Dr. Mascaro's phone, and they're both the same.
Oh,
Lloyd and
okay.
Murphy. Murphy, not McMurray. Murphy.
Murphy is the.
That, or
gallbladder.
then it's,
So,
what did I say it was?
McMurray?
McMurray.
Okay, but in any case, we're trying to get away from using people's last names as examinations. So we're going to call it CBA tenderness, costovertebral angle tenderness. Okay? And so what we're going to do is place the picture there on 464 also helps at the bottom. Place the ball of one hand. First off, I want to tell you, this is a punch to the back. This is not mixed martial arts. So we're not in the octagon. I just like saying that. Does anybody say that anymore? Yeah. I get it from Napoleon Dynamite, I think. Remember that? His brother? So basically, Dr. Anderson really lets his patient know that this is going to be uncomfortable.
I didn't let her go last
Even if
year.
it doesn't have any inflamed kidney, you're going to see with each other that it's uncomfortable. So he told her, and why we say, why don't we even put that hand there? And some people you'll see will just tap, tap on both sides, punch, punch on both sides. It really is it's not a tap, it's a punch, okay? But we put the hand there, and part of the reason I think we put the hand there, can you show again?
Sure.
And then punch, is because then Crystal, instead of just going, hey, I'm gonna punch your back, okay? With that, the hand is there so that she knows proprioceptively where I am about to hit, and then it kind of dulls it a little bit, because if that that capsule, renal capsule is really inflamed, then that's gonna really hurt. So it's just I think it's a more friendly version of doing it. And you do both sides, okay? Even if, yes, Catherine.
If it's inflamed, why would we have to hit that hard?
If it's inflamed, why would we have to hit that hard? Because sometimes there may be just a slight amount of inflammation, but it can give us a clue as to what's going on. So we want to make sure we're not missing anything, as opposed to, there's the balance of not wanting to miss any tenderness, but hurting them too, to the point of anybody would be screaming in pain and bleeding, So it's a fine balance of how much pressure, but so practice with your attendings, and they'll show you how hard. Be careful with each other, okay? Let your person know when you're about to do it. It does, even thinking about it, just sort of makes my hand hurt, because I know what it feels like. So be gentle with each other, but definitely do punch, okay? Let's see. Then we're going to move on to one last thing, the bladder. Part of, as you know, when you have a kidney infection, you may have bladder distension, you may have urinary hesitancy, where your body physically does not want to initiate urination. You may have urinary retention. So what we're going to do is make sure, if we try to figure out if we can notice if the bladder is distended. And what you do is, first off, the bladder is usually only palpable if it's distended above the pubic symphysis, so that's already quite a bit of distension. So this again may not be the most, fruitful exam for you. You may not feel anything. Although last year, I do remember a student took one for the team and drank so much water. Do you remember that, Dr. Stewart? I saw them running. They just come they had drank so much water, so I'm not going to recommend that, because I didn't want him to get hyponatremic or something, but I think it was he did that. They felt the bladder, and then he ran to the bathroom. So I'm not telling you to do that, but that might be the only way to do it. So basically, you're going to percuss to determine the height of a distended bladder. So first off, you palpate. So pretty much I usually palpate the bladder. I do from the umbilicus, kind of coming down, so if I can feel anything. And then if I were to feel the top of the bladder, I would measure how many centimeters it's distended by percussing and determining the height of a distended bladder, distance in centimeters from the top edge of the bladder to the pubic symphysis, okay?